Good afternoon and welcome to the Department of Medicine Grand Rounds. Our speaker today is Dr. Matthew Clifford Rashotte. Dr. Clifford Rashotte is an assistant professor in the Division of Infectious Diseases. He completed his medical training at McMaster University, followed by internal medicine residency at UFT and infectious disease subspecialty residency at University of British Columbia. He completed clinical educator fellowship at UBC, a Center of Health Education Scholarship, and a Master in Health Profession Education at Maastricht University. Before joining McMaster Infectious Disease Division in 2023, so Matthew's been with us for about a year. His clinical interest is in general ID and HIV, and his research and scholarship is focused on medical education. Matthew is going to talk to us today about update on invasive group A streptococcal disease. Matthew, please go ahead.
Thanks very much for the introduction, and thanks for the opportunity to present to you all today. So I'll be providing an update on invasive group A streptococcal disease, which is a condition that we're seeing with increasing frequency. And so hopefully this has broad relevance for our audience today. Before beginning, I'd like to take a moment to acknowledge with gratitude and respect that both McMaster University and Hamilton Health Sciences stand on the traditional territory shared between the Haudenosaunee Confederacy and the Anishinaabe Nations, and that this is recognized in the Dish with One Spoon Wampum Belt Agreement. With respect to disclosures, I have none. So why this topic? As I mentioned, we're seeing increasing numbers of invasive group A streptococcal disease, not only in Canada, but also across many countries. And this is increasingly a condition which we are also seeing in the news. So I thought that this was something newsworthy that I wanted to share with the group and provide a bit of an update on. So to that end, my objectives are to describe the spectrum of group A streptococcal disease, in particular focusing on invasive group A streptococcal disease, to review the management the approach to management of invasive group A strep, including both antimicrobials and adjunctive measures, and then to talk about the changing epidemiology of invasive group A strep, both locally and globally, and to discuss some of the factors that might be driving the increasing case numbers that we've been seeing. And then finally, to talk about prevention measures for invasive group A strep, so infection control considerations, management of contacts, and then I'll briefly highlight the status of some ongoing vaccine research. So before I do that, I'd like to provide a bit of a historical digression. I think one of the most fascinating things about the field of infectious diseases is the history of the conditions that we treat. So before getting into some of the more contemporary news, I wanted to provide a bit of a historical overview of what we know about streptococcal diseases and how they came to be known. So streptococcal diseases have been really known since antiquity. What we now know to be diseases caused by streptococcal infection have been described dating back to the time of Hippocrates. It was he who coined the term erysipelas from the Greek for red skin in the 4th century BC. Centuries later, the syndrome of what we now call scarlet fever was first described throughout the 1500s, and it was labeled scarlatina finally by Sydenham in 1675. Streptococcal diseases and the treatment thereof were really essential to the discoveries made by Semmelweis in 1842. He demonstrated a dramatic decrease in mortality from peripartum fever with the implementation of chlorinated hand washing for medical attendants on an obstetrical ward. At the time, this was before germ theory was known, before infectious diseases as we know them now were known in any capacity, but he found on medical wards that attendants attended their patients who had died at autopsy in the morning before performing their clinical rounds, and before knowing anything about bacteria or their transmission, theorized that they must be in some way transmitting disease from their patients who had died to their patients who were living, and so implemented chlorinated hand washing. And at the time, his findings were extremely controversial. It wasn't until decades later that streptococci were actually discovered and corroborated what he had observed. So Bill Roth, an Austrian surgeon, is credited with first describing streptococci in 1874. He found them in patients who had erysipelas or wound infections and coined the term streptococcus from the Greek for twisted chain of berries. It was Pasteur in 1879 who found streptococci in the blood and uteruses of patients who had died from peripartum sepsis, corroborating the findings of Semmelweis about an infectious cause of peripartum sepsis and fever. And then Rosenbach in 1884 identified these bacteria from suppurative lesions and provided the name Streptococcus pyogenes, meaning pus forming. So technological advancements in microbiology continued through the 20th century, really importantly with blood agar differentiation. It was Brown in 1919 who distinguished alpha or partial hemolysis from complete beta hemolysis and gamma hemolysis or lack of hemolysis. And we know now what we call Streptococcus pyogenes belongs to the beta hemolytic group of streptococci. And we'll talk a bit about the virulence factors that contribute both to hemolysis and to some of its pathogenic manifestations in humans. And then I would be remiss to not mention Rebecca Lansfield, who was an American microbiologist who made a major contribution in differentiating streptococci into various groups based on their surface carbohydrate antigens. And so this is where group A, group B, group C, et cetera, all derive from. Most pathogenic strains in humans were designated serogroup A, and then she went on to classify serogroup A strains further based on the surface M protein and discovered its role as a major virulence factor. And M protein is still how we further type and differentiate group A strep, and I'll talk about that a little bit in the context of the current epidemiology. So equipped with that knowledge about the microbiology of streptococci, we're able to better delineate the clinical presentations caused by this pathogen. And what we know is that disease really exists along a spectrum. So patients may have asymptomatic carriage or so-called colonization. We know that a proportion of healthy individuals will carry group A streptococci in the oropharynx or on the skin. Those can be transmitted from person to person, and we know that humans are really the only important environmental reservoir for group A strep. In cases where there's a local immune reaction, superficial infection can develop. So far and away, the most important disease manifestation, or most common disease manifestation caused by group A strep would be streptococcal pharyngitis, and then superficial skin and soft tissue infection like impetigo. Depending on host factors and pathogen factors, invasive infection can also develop, and that'll be the bulk of what we talk about today. And then importantly, there are some immunologic sequelae that have been major contributors to morbidity and mortality from streptococcal disease. So just to present this visually, we know that the disease manifestations can really affect any organ system. So pharyngitis, peritonsillar abscess, otitis media, sinusitis being some of the more common presentations. But the central nervous system can also be involved with meningitis or brain abscess. We see lower respiratory tract disease characterized by pneumonia or empyema. There's primary bacteremia from group A strep, and this can in some cases be complicated by endocarditis. The disease manifestations involving the skin and soft tissue are among the more common, and they range from the superficial impetigo to progressively deeper tissue involvement. So erysipelas, cellulitis, myositis, and in extreme cases, necrotizing fasciitis. We know it to be an important cause of peripartum and postpartum sepsis. And we also see osteomyelitis and septic arthritis. This is probably a non-exhaustive list, but this is among the most common disease manifestations. We also see immune-mediated sequelae, so acute rheumatic fever and rheumatic heart disease being a major cause of morbidity and mortality from group A strep disease, as well as post-streptococcal glomerulonephritis. And then there are a couple of key toxin-mediated syndromes. So scarlet fever, which we commonly see in children with rash and mucocutaneous involvement, and then a syndrome that we'll dive into in a bit more detail, which is the streptococcal toxic shock syndrome. So how have these disease presentations changed over time? So the current epidemiology of rising cases of invasive group A strep is somewhat of a contemporary phenomenon, so I wanted to trace a little bit over the last decades how these disease presentations have shifted. So scarlet fever through the 19th century was a major cause of childhood morbidity and mortality. The mortality from scarlet fever started to decline in industrializing countries beginning in the late 19th century. This predates the advent of antibiotics. So the reasons for that decline are not completely understood, but it's theorized that strains began to circulate that had less pathogenic potential or less toxin production as far as scarlet fever pathogenesis was concerned. As we know, in the 1940s, penicillin became widely available, and this had a dramatic effect on rheumatic fever incidence, particularly in Canada, the United States, and Europe. And beyond the mid-20th century, rheumatic fever became exceedingly rare in these places where it had once been quite common. The majority of group A streptococcal disease now occurs in low and middle income countries related to issues of healthcare access. And in high income countries, the greater burden of disease, unfortunately, is experienced by communities that are experiencing social marginalization or those who might have decreased healthcare access. So with the broad decline in rheumatic fever and scarlet fever, a new syndrome in the 1980s began to be described, and this is the streptococcal toxic shock syndrome. So it was first described by Cohn et al. In a publication in JAMA in 1987. They described 2 patients in the United States who presented with severe group A streptococcal infections. These patients had a clinical presentation similar to the staphylococcal toxic shock syndrome that had been described a few years earlier, but with confirmed group A strep disease. Subsequent series were published with larger numbers of patients. There was increased clinical recognition of this entity. And in 1993, a group convened to create a standardized case definition. So what is the streptococcal toxic shock syndrome? How do we define it? So there are clinical criteria. Patients must have hypotension characterized by a systolic blood pressure less than 90 in adults, and some manifestation of end organ dysfunction. So generally, at least 2 of renal impairment, coagulopathy manifest by thrombocytopenia or DIC, liver enzyme abnormality, respiratory involvement in the form of ARDS, and a generalized erythematous macular rash. In addition to those clinical criteria, there are laboratory criteria. Of course, this needs to be linked to group A streptococcal infection. So a confirmed case will involve isolation of group A strep from a sterile site, and a probable case will involve isolation of group A strep from a non-sterile site in cases where no other etiology appears to be to blame. So how does group A strep cause these heterogeneous disease manifestations, and in particular, how does it cause toxic shock? So group A strep probably has greater heterogeneity in virulence factors than any other known human pathogen, and it's also one of the best studied. So I wanted to highlight here a non-exhaustive list, but of some of the most important virulence factors that Streptococcus pyogenes possesses. So starting from the left, there's a hyaluronic capsule, which, as all capsules offer to bacteria who possess them, it slows phagocytosis and slows the host response. There's a surface-bound M protein, which we mentioned, discovered by Lansfield and used for typing different group A strep. This also has important functions for immune evasion. So it is able to bind immunoglobulins, it's able to bind complement regulatory proteins, and in doing so, it helps evade complement and the host immune response. There are a number of secreted virulence factors. So I've highlighted here streptolysin S and O. So these cause cell lysis of eukaryotic cells. They're responsible for the hemolysis that we see on blood agar, that clear zone of beta hemolysis. They also inhibit phagocyte function, and they activate platelets and endothelial cells. So you can imagine in an area of infected tissue, by activating platelets and endothelial cells, they decrease oxygen delivery to tissues, they promote tissue ischemia and necrosis, and they're essential for ulcer formation and also deep tissue invasion. Next, hyaluronidase and streptokinase, similarly enzymes that help degrade host tissues and facilitate deep tissue invasion. Next, C5a peptidase, which is a surface-bound protein. This, by inhibiting C5a, inhibits complement activation and host immune response and inhibits neutrophil chemotaxis. And then finally, perhaps most interestingly, are the streptococcal pyrogenic exotoxins. So these are secreted toxins which act as superantigens. They have a host of downstream effects on the immune system, resulting in T-cell anergy and decreased antibody synthesis. So what is a superantigen and how does it work? So superantigens are interesting in that they activate T cells in a non-specific manner. So they result in a massive cytokine release and downstream inflammatory cascade. In this image here, we can see on the left sort of the typical interaction between MHC class II and T cell receptors. So typically, peptide antigens are presented on the surface of MHC class II. They're recognized in a specific manner by the T cell receptor, and they result in T cell activation. Superantigens on the right are distinct in that they're able to cross-link MHC class II and the T cell receptors directly. So they do so via two separate binding sites, one on the MHC class II and one on the T cell receptor, usually the beta chain. In doing so, in activating T cells in such a non-specific manner, they're able to activate, at some estimates, up to 20% of the total pool of T cells, which is results in cytokine storm, massive release of interleukins 1 and 6, TNF alpha and beta, interferon gamma, and they're able to produce an endotoxin like shock, which has downstream deleterious effects on the host immune system, resulting in T cell anergy, decreased antibody synthesis. And the streptococcal pyrogenic exotoxins are really essential to the pathogenesis of the toxic shock syndrome, which we see is manifest by hypotension and end organ dysfunction. So how has this epidemiology evolved to the present day? So toxic shock syndrome, as mentioned, was first described in the 80s, and it, along with other invasive forms of group A strep, was increasingly recognized throughout the 80s and 90s. And finally, invasive group A strep became a nationally reportable disease in Canada starting in the year 2000. And I showed you headlines from the present day, but if we look back in time, this is not the first time that invasive group A streptococcal disease has been in the news. And in fact, there have been a couple of decades of media attention on gradually increasing the cases. So invasive group A streptococcal disease is a broader clinical entity than just the toxic shock syndrome. And so how is that defined? When this became reportable in the year 2000, there was also a national case definition to go along with it. So a confirmed case involves isolating group A strep from a normally sterile site. So this can be blood, CSF, pleural or pericardial fluid, a deep tissue specimen that's taken during surgery. So for example, a deep tissue debridement of muscle in surgery for necrotizing fasciitis, and then bone or joint fluid. A probable case is characterized by invasive disease. So invasive disease could be the toxic shock syndrome, soft tissue necrosis, or meningitis. And in this case, there's no other apparent etiology, and group A strep has been isolated from a non-sterile site, for example, a superficial skin abscess or a superficial wound swab. And then finally, pneumonia from group A strep, when it's isolated from a BAL, usually is treated by public health as invasive, but technically doesn't meet the national case definition because BAL is not prepared as a sterile specimen. So what are the risk factors for invasive group A strep? Why are some individuals more susceptible to this disease? So we know it lives in the oropharynx and lives on the skin. So any type of cutaneous trauma, wounds, burns, recent surgeries, anything that violates the skin barrier and inhibits that response will increase risk. We know importantly that certain preceding or coexisting viral infections, in particular influenza and varicella, are associated with an increased risk of invasive group A strep. In the case of varicella, it appears to be clearly linked to the disturbance of the skin from cutaneous lesions. Immunocompromise of various types increases the risk given the inhibited host response. We know that peripartum or postpartum status is a risk factor associated with ascending infection. Substance use, in particular injection drug use, is a major risk factor. And then environmental risk factors are really important to highlight. So individuals in crowded environments where there's more likely to be person-to-person transmission are at increased risk. So this might include individuals in shelters, dormitories, or military barracks. Contacts to a case of invasive group A strep are at increased risk. The exact magnitude of that increased risk is a bit of a matter of debate, and I'll touch on that in a moment. And then finally, individuals who are either younger or older, below the age of 5 or above the age of 65, are at increased risk. So how do we manage invasive group A streptococcal disease clinically? So there are a number of key components of management, 4 here that I've highlighted. So first is the general management of sepsis with fluids and vasopressors, as is routine. Second, really important to highlight is that if necrotizing soft tissue infection is present, then early surgical debridement is really essential. Delayed surgical debridement of necrotic soft tissue infection is associated with dramatic increases in mortality. So it's important that this be identified and managed expeditiously. Then antimicrobial therapy, of course, is important with initial empiric therapy based on the syndrome. And then finally, adjunctive or antitoxin measures are often employed. So for the purposes of today, I'll speak about the latter 2 categories. So antimicrobial therapy. So as I mentioned, your initial empiric therapy is going to be based on the clinical syndrome with which your patient presents. But once group A strep has been identified as the causative organism, we'll then move on to targeted therapy. So we know that group A streptococci are universally susceptible to penicillins, along with other beta-lactam agents. So penicillin G is usually recommended as definitive therapy. We also recommend adjunctive clindamycin for the antitoxin effect in cases of invasive group A strep. And why is that? So in vitro, there is a thought that clindamycin may be more effective than penicillin in high inoculum infections. So initially in infection, bacteria undergo log phase of growth, rapid replication, and increase in bacterial numbers. Then they enter into stationary phase growth. Stationary phase growth particularly might be seen in necrotizing soft tissue infections in cases where there's limited environmental resources for which bacteria are competing. And there's some evidence that during stationary phase growth, bacteria express lower levels of penicillin binding proteins on their cell surfaces. Penicillin binding proteins, of course, are essential for penicillin to bind to exert its antibacterial activity. And so there's some thought that clindamycin, because it is a protein synthesis inhibitor that acts directly on ribosomes, might overcome some of this decreased activity at stationary phase growth. Also, as a protein synthesis inhibitor, it's able to block the formation of a number of important virulence factors. So the M protein, the streptococcal pyrogenic exotoxins, and streptolysin S. And given the toxin-mediated processes that we see, for example, with the toxic shock syndrome, this is an appealing option. So what's the clinical evidence? So this is taken from a 2023 publication just from a couple a year ago in Clinical Infectious Diseases. The authors here looked at a number of studies from 1997 to 2022, specifically looking for patients who received or did not receive clindamycin in the context of invasive group A strep infections. And they found overall decreased mortality in the clindamycin-treated group with an odds ratio of 0.45. So this generally informs our recommendation to use adjunctive clindamycin in invasive group A streptococcal infections. So the role of clindamycin is short-lived. We know that clindamycin is associated with increased risk of adverse effects like C. difficile colitis compared to definitive therapy with penicillin. So you really want to discontinue clindamycin once patients are clinically stable. Usually that's after 48 to 72 hours of initial therapy. There's an increasing question of what to do in cases of clindamycin resistance in group A strep. So I mentioned that group A strep are universally susceptible to penicillin, and resistance to clindamycin used to be rare, but has increased slightly over the last couple of decades. According to our local data out of Hamilton Health Sciences, and thank you to our ID and stewardship pharmacist, Neil Irfan, for sharing this data with me. 88% of our isolates are clindamycin susceptible. This is from mid-2022 to the present. Although I should mention this doesn't stratify invasive versus non-invasive isolates. And the national data at this point would suggest that in invasive isolates, the risk of clindamycin is somewhere in the range of less than 5%. So still reasonably active. Although I'll mention that in cases of confirmed clindamycin resistance, linezolid can be considered as an alternative antitoxin antibiotic. It has similar mechanism of action in terms of being a ribosomally active protein synthesis inhibitor, though it doesn't have the wealth of clinical experience and data that clindamycin has. So what about IVIG? This is the other adjunctive measure that's often discussed. So IVIG is appealing because we know it has a range of immunomodulatory actions, including immunosuppressive and anti-inflammatory properties. And we know that the toxic shock syndrome is a hyperinflammatory condition. There's in vitro data that IVIG might result in neutralization of group A streptococcal virulence factors. And there's observational data that patients with severe group A strep, as compared to those with non-severe disease, tend to have lower levels of circulating antibodies against these virulence factors. So there's plausible mechanism by which giving additional IVIG might help neutralize those virulence factors and might result in a better outcome for patients. So what's the evidence for IVIG? So until 2018, there were mostly small observational studies providing inconsistent evidence. This 2018 systematic review and meta-analysis, also published in Clinical Infectious Diseases, looked at the effect of IVIG on mortality in patients with streptococcal toxic shock syndrome treated with clindamycin. And this is an important stratification because we know that clindamycin has benefit for these patients, yet many of the studies either didn't comment or didn't stratify among patients who did or didn't receive clindamycin. Secondly, a lot of the observational studies included heterogeneous patient populations, so included patients with invasive group A streptococcal disease, but might have also included patients with necrotizing soft tissue infection caused by other organisms. So the real strength of this study was that they stratified for a specific patient population in whom we're most interested in the benefit of IVIG, and that's those patients with confirmed toxic shock syndrome who are receiving clindamycin as part of the standard of care. And what they found is that mortality in the IVIG group was 15.7% versus 33.7% in the non-IVIG group. So though this is based on small studies, of course, with a risk of bias, overall these favor administration of IVIG. And it's important to mention that there's no evidence of benefit for the use of IVIG in necrotizing soft tissue infections that are caused by other pathogens. So this appears to be a group A streptococcus specific effect. Okay, so beyond the management of the individual patient, I wanted to highlight some aspects of infection control and contact management. So infection control in the inpatient setting where most of these patients will be seen with invasive group A strep is to maintain droplet and contact precautions until 24 hours of effective antibiotic therapy has been completed. Of course, by the time that we receive a microbiologic diagnosis, often this 24-hour window has closed. So this just highlights the importance of having an index of suspicion when patients present and placing them on appropriate precautions based on the syndrome. So what about contact management? So do close contacts of invasive group A streptococcal disease benefit or require prophylaxis? And the American and Canadian guidelines actually differ with respect to their recommendations. And this is likely because of a couple of major studies on which their recommendations are based that found varying risks of disease in close contacts. So I've highlighted the results here of a large Canadian study completed from 1992 to 1995 in Ontario versus a US study completed a couple of years later across multiple US states. The Canadian authors, using public health surveillance data across Canada, found 732, or across Ontario rather, found 732 sporadic cases for an incidence of 2.4 per 100,000. The US study, 1,064 cases for a slightly higher baseline incidence of 3.5 per 100,000. In the Canadian study, there were 4 subsequent cases among 1,360 contacts. So a subsequent case being a case within the 30 days after the initial case was diagnosed. And the US study found a much smaller number, just one subsequent case among over 1,500 contacts. As a result, the Canadian study, the data resulted in an attack rate of 294 per 100,000. The American study, an attack rate of 66, with a really wide confidence interval, of course, reflecting the fact that they only identified a single subsequent case. So on this basis, combined with the fact that there's no randomized data on the effectiveness of prophylaxis, given that it's such a rare event, we also know that prophylaxis might be associated with antibiotic side effects, increased antibiotic resistance, both in the patient and in the community. The guidelines differ. So the Canadian guidelines do suggest offering prophylaxis for close contacts of severe cases, and I'll define what that is in a moment. The US guidelines, which came out a couple of years earlier, suggest that prophylaxis might be considered for close contacts who are at increased risk of death, and they particularly focus on those who are age 65 and above, because that appeared to be the most consistent risk factor associated with death in subsequent cases. So how do we manage close contacts according to the Canadian guidelines? So again, prophylaxis can be offered if it's both a severe case and a close contact. So a severe case is defined more narrowly than just invasive group A strep. It's a case of the streptococcal toxic shock syndrome, soft tissue necrosis, meningitis, pneumonia, or death secondary to infection. And a close contact is defined as someone who, in the 7 days before illness onset up until 24 hours after antibiotics were administered, had extensive contact with the case. So either a household contact, spending at least 20 hours per week with the case, non-household contacts who have either shared sleeping arrangement or who are sexual partners, contacts who've had direct contact with mucous membranes or oral secretions, or direct contact with an open skin lesion, shared needles in the context of injection drug use, children and staff in home daycares, and then some contacts in long-term care. So a severe case and close contact are both fairly narrowly defined for the purposes of prophylaxis. So what are the prophylactic regimens that are recommended? So the first line is first-generation cephalosporin. This is either cephalexin or cefadroxil for 10 days. And second line is either a macrolide. The authors recommended erythromycin or clarithromycin because they're found to induce less cross-resistance than azithromycin, which we more commonly use, or clindamycin. But of course, in those cases, you'd want to confirm susceptibility in the index case because we know there's not universal susceptibility. Why cephalexin or cefadroxil and not penicillin? Because we know group A strep are universally susceptible to penicillin. In devising this recommendation, the authors extrapolated from some data that oral penicillin is associated with higher failure rates at the clearance of oropharyngeal carriage in patients who are treated for pharyngitis. So there's no head-to-head comparative data in the prophylactic context, but they've sort of extrapolated based on the available data of treatment. So what are the recent epidemiologic trends? What have we been seeing over the last number of years? So as I mentioned, invasive group A streptococcal disease became nationally reportable in Canada in the year 2000. Though we've seen a lot in the news over the last couple of years, cases had actually been rising prior to the COVID-19 pandemic. There was a sharp decrease in cases during 2020 and 2021. Not surprisingly, given all the mitigation measures that were implemented for COVID, there was decreased person-to-person spread of a number of infectious diseases. There was a subsequent rebound in 2022, particularly in the latter half of the year, and now record case numbers have been reported in 2023. So where does the national data come from? So the National Microbiology Laboratory in Winnipeg receives invasive group A strep isolates from laboratories across Canada. They then compile surveillance data, and they do EMM gene typing for group A strep. So the EMM or M gene encodes the M protein. And as I mentioned, this is still discovered by Lancefield. This is still how we differentiate among different strains of group A strep. There are over 240 M types that have been described. And really impressively, NML does whole genome sequencing for all these invasive streptococcal isolates as of 2022. So they're generating huge amounts of data that's really interesting and helpful from a public health standpoint. So what's been happening with cases in Canada? So this figure is the most recent publication released by PHAC. They haven't yet published their 2022 or 2023 data. So you can see here that going back to the year 2000, cases had slowly been rising, peaking in 2018, 2019, before a sharp decrease in 2000 and 2021. Cases increased toward the end of 2022, and then in 2023, a record number of invasive isolates were received by PHAC. So they haven't yet finalized their data, but they've been reporting in some presentations that they've received over 4,800 invasive isolates of group A strep in 2023. And you can see on the graph here, our upper limit is 3,500. So a dramatic increase year over year. The number of isolates doesn't always match one-to-one with cases. It should, but it's generally a pretty reliable indicator. So the number of cases, though not yet reported, is likely to be somewhere in that range. So as I mentioned, a record number of cases in 2023. Typically with invasive group A strep, there's some seasonal variation because of person-to-person spread, risk factors being influenza. There's often a seasonal variation with cases spiking over the winter months. Interestingly, in 2023, that seasonal variation was observed to a much lesser degree. So there were fairly high levels throughout the summer months, and the nadir of cases wasn't actually seen until September. And among EMM types, I mentioned there are over 240. EMM1, at least based on 2023, represented the greatest number of cases. So about half of those identified in individuals under 15, and about 20% of those in individuals over 15. And I'll talk a little bit more about a particular strain of EMM1 that's of some public health interest. So what's happening in Ontario? So this is data from Public Health Ontario, which is a bit more updated. As you can see, they've published a summary of disease activity from October 1st, 2023 to February 29th of this year. They published this just about 3 weeks ago. So they have very updated data that they've shared with us. So we can see here, this is confirmed invasive group A streptococcal cases by month. In dark blue is the current season of 2023 to 2024. In purple is the 2022 to 2023 season. And then in green is the average of the seasons from 2014 to 2019, excluding the COVID years, which were outliers. So you can see in dark blue here, a pretty significant increase month over month compared to case observations in 2022, 2023. And I'll mention here that the drop-off in February is subject to change because they just published this a couple weeks into March. There's likely a reporting lag, so this number is subject to change. But this clearly demonstrates that cases have continued to rise for the last couple of years. And how is this distributed across the province? So most of the province is seeing fairly uniform levels of disease activity, including us here in Hamilton. But there are areas of increased activity, particularly in the eastern parts of the province, and then in the north and particularly northwestern regions. So Public Health Ontario has also shared really interesting data about EMM types. So I'll just draw your attention here to EMM1, which I mentioned was becoming the most common type spread across Canada. So in the current season, they've EMM typed about 60% of the isolates so far. And in those 18 years of age and above, about 35% of the cases are EMM1. Last season, EMM1 represented just about 7% of the cases in adults. And in the pediatric population, this is even more dramatic. So 70% of the cases in the pediatric population this season are EMM1 compared to 40% last year. So this is a global phenomenon. This is by no means confined to Canada, and a number of countries have been reporting increasing cases, including the United States, a number of European countries, Australia and Japan, among many others. So what's driving this and what underpins the global rise in invasive group A streptococcal infections? There are a number of theories. So one, we know that viral infections, in particular influenza, increase the risk of concomitant or subsequent invasive group A streptococcal infection. We know that these respiratory viral pathogens really rebounded after the COVID-19 pandemic. So it's thought that there are more group A strep following increased rates of viral respiratory tract infection. And further, because of the mitigation efforts, which successfully reduced the spread of COVID-19, they also resulted in less person-to-person transmission of group A strep, less exposure and less development of immunity to these circulating EMM types, which might have helped a particular EMM type now predominate against a population that has increased susceptibility. So I wanted to highlight in particular an EMM variant that has been increasing and has generated a lot of attention. This is the EMM variant M1UK. So this strain dates back to an outbreak of scarlet fever that was first described in England in 2014. This was followed by an increase in cases of invasive group A strep a couple of years later. And the public health authorities there found that they had an increased proportion of EMM1 isolates, and whole genome sequencing identified a new variant with a couple of single nucleotide polymorphisms that they've called M1UK. There's in vitro data and emerging clinical data that EMM1 or M1UK strains are associated with a hypervirulent phenotype. So in vitro, M1UK isolates produced the virulence factor SPEA, or the streptococcal pyrogenic exotoxin A, ninefold higher rates than the pre-existing circulating strains. We know that the streptococcal pyrogenic exotoxin A is really important in the pathogenesis of scarlet fever and the toxic shock syndrome. So this correlates with the increased rates of those clinical conditions. So after first being described in the UK, this strain has also been identified in Canada, the United States, a number of European countries, Australia. And per preliminary data that NML has shared in some presentations, about 60% of the Canadian EMM1 isolates in 2023 were M1UK. And if we look back to the Ontario data and we see the fact that EMM1 strains have increased so much even in the current season, though the typing hasn't yet been done, one would reasonably predict that many of these will be M1UK. So what can we do for prevention? So I think a huge focus needs to be provided to the social determinants of health. We see in our patients who are most susceptible to invasive group A streptococcal disease that factors like housing, access to sanitation, treatment and access to care for substance use are really important drivers, not only of invasive group A streptococcal disease, but a whole range of adverse health outcomes, particularly in the realm of infectious diseases. So considerable attention needs to be provided in that regard. We know that we have vaccine preventable diseases that may precede invasive group A strep, so in particular influenza and varicella, so encouraging vaccination for those conditions is important. So what about a vaccine for group A strep? I think this is an interesting area of research, and so I wanted to highlight that briefly. So group A strep vaccine development has been unfolding for decades. Unfortunately, early vaccine candidates, like many vaccine candidates, were very reactogenic, did not successfully prevent subsequent infections. In the 1940s, they were injecting whole-killed bacteria. In the 1960s, they tried M protein vaccination in adults, and these were not protective. There was one uncontrolled study looking at siblings of patients who had developed acute rheumatic fever and graduated doses of M protein vaccination. And this one study reported 3 cases of acute rheumatic fever in children who, after the vaccination, had gone on to have subsequent streptococcal infections. And because of the concern over this data from this very small trial, the US FDA actually banned subsequent vaccine trials of group A strep due to concern of cross-reactivity. And it wasn't until 2006 that this ban was overturned. So a number of lost years of potential research and development into vaccines. So what's in the pipeline now? There's nothing that's ready for prime time. Generally, vaccine targets are either M protein based or non-M protein based. M protein, of course, being a major virulence factor and a way that we identify circulating strains. So the study that, or the vaccine candidate that I believe is furthest along the pipeline is a 30-valent M protein vaccine, which completed a phase 1 study in 2020. Reassuringly, they found significant immunogenicity to the desired antigenic targets. They didn't find any autoimmune or cross-reactive antibodies. The challenge is that the areas of highest need, which are low and middle income countries, also have the highest heterogeneity of circulating M types. So designing a vaccine that has adequate coverage against M types in a defined region is the challenge. There's some hope that there is, beyond type-specific immunity, there might be clade-specific immunity, which a clade encompasses multiple types. So there's hope that perhaps a 30-valent M protein vaccine might actually provide activity against a greater number of strains. And then there are non-M protein-based vaccines. So of course, the group A carbohydrate would be of interest because it's conserved. It's how we identify group A strep. The challenge is that there's a side chain, an N-acetylglucosamine side chain, that's thought to potentially be implicated in immunologic sequelae. So there are preclinical studies now using a knockout with that side chain. And there are a number of preclinical studies looking at SLO, among other virulence factors and other key molecules. So though there's nothing coming down the pipeline imminently, in 2019, a Strep A Global Vaccine Consortium was established to help accelerate research and development for a vaccine in the hopes that we may someday have a more robust way of preventing disease across the world. So with that, I'll provide some of my references there, and I thank you all for your time and interest. Happy to field any questions or comments for discussion.
Thank you so much, Matthew, for this overview. I appreciate the preventive part and the public health parts, things that we don't see usually and deal with in hospital practice. If you have a question, please add it to the Q&A, and we can take these questions as they come in. And if you want to ask your question in person, please just raise your hand and I will allow you to speak. Matthew, there's a question from Rose Patterson, actually. It's interesting. It's talking about, is there any talk among public health channels for making the home rapid strep test available for the public, similar to the COVID tests, so to allow people to quickly identify group A pharyngitis and start treatment early?
Yeah, it's a good question. I'm not aware of any. I think the challenge is that to do rapid testing for strep, ideally there's some risk stratification, like based on the clinical factors. So providing these widely, I'm not sure, the discerning potential. We know that there's asymptomatic carriage of group A strep, and so there's potential confounding there. And the hope, I guess, would be that patients would seek out care for early treatment. The major benefit of treating pharyngitis early would be the prevention of later immunologic sequelae like rheumatic fever, which fortunately in most parts of Canada are really rare at this time.
That's a good thought. I mean, we'll find people just asking for more antibiotics. It's going to be no problem, right? The question from Neil, can you comment on the quality of data for clindamycin for adjunct invasive GAS?
Yeah, so it's, as Neil well knows, the data are of pretty variable and pretty low quality, a lot of observational studies. I think the compelling, argument for clindamycin is that there is high mortality observed with penicillin monotherapy. There's in vitro data. The best clinical data we have available, suggests a benefit. So I think, it's important to not administer it indiscriminately. We know clindamycin is associated with more antibiotic side effects than our typical beta-lactam agents. But I think in the right patient who presents with shock or severe invasive group A strep infection, there probably is a role. But again, for a very limited duration of therapy with a clear endpoint of stopping once there's been clinical improvement after a couple of days.
All right. So question, that's great. Thank you, Matthew. It's a question from Dr. Levine about how come we have a successful strep pneumo vaccine and we're struggling getting a vaccine for group A strep.
Yeah, that's a great question. I'm, admittedly not a vaccinologist, but based on my reading, what I can say is that streptococcal vaccines targeting the carbohydrate capsule have been successful. The challenge with group A strep is that the capsule is hyaluronic acid, which of course is present in human tissues. So an hyaluronic acid vaccine is not possible. Concerns with the immunologic sequelae. So unlike pneumococcal disease, group A strep has really well described immunologic sequelae that have driven a lot of morbidity and mortality over the decades. So that FDA ban, whether justified or not, I think really decelerated the rate of vaccine development, at least in the United States. But hopefully M protein targets, provide us something in the coming years. I think that's an interesting development pipeline.
Thank you. There's a question from Dr. Daniel Brand Vegas about, can you give us more information or comment more on the association between, you mentioned respiratory infections, influenza and others, and group A's streptococcal infection?
Yeah, so as we know, influenza A is associated with subsequent bacterial pneumonia in some patients. There's local tissue destruction, there's alterations in immunity. So particularly well described as staphylococcal infection, and group A strep infection is also described. So it's among the more consistent of risk factors that have been identified, looking at the association of respiratory pathogens. So preceding influenza, followed by then clinical deterioration with fever, signs of sepsis, one should be thinking about a subsequent bacterial infection, and some of the more common etiologies would be Staphylococcus aureus and group A streptococcus.
Okay, thank you. I found interesting the fact that you shared with us about penicillin having a lower efficacy in oropharyngeal clearance, although it's the mainstream treatment. And even for oropharyngeal infection, I mean, some use Geflex, but penicillin is also used. So what is the, I mean, is this like is a strong data that recommended based on, or is this something that has some scientific plausibility?
Yeah, I think the challenge with the data from what I've seen, it's mostly with oral penicillin, which we know there are issues with bioavailability. There's a maybe biological plausibility in the theory that perhaps there are reservoirs in the oropharynx where the expression of penicillin binding proteins may be decreased. I don't think it's particularly robust data, but I think it's what was available at the time that sort of informed those recommendations. So, penicillin or amoxicillin, which we use more commonly now, would still be first line, but those prophylaxis guidelines are in favor of first generation cephalosporin.
Fantastic. I have a question about when you mentioned about contact prophylaxis, and it's as an inpatient physician, it doesn't come to my mind usually when you have a patient with the strep A to discuss with them their contacts and prophylaxis. Is this something that usually fully covered by public health, and is it done in a timely manner usually when by the time they get the results or the reporting, and then they go contact tracing like other infectious diseases, or is this something that needs some clinician input as well at the bedside, as all of us practicing in hospital and seeing these infections?
Yeah, I think my understanding is that sterile isolates will be directly reported to public health by microbiology. That is my understanding. I think if there's a clinical syndrome that you feel is probable or perhaps might not be routinely reported by the lab, that would be something worth alerting public health to. I believe they will follow up with contacts in a timely fashion. As we say, the threshold for what constitutes severe disease and what constitutes a close contact is pretty high, and the quality of the evidence on which prophylaxis is based is very low. So, I'm not sure that the incremental benefit is great, but because it's such a rare event, it proves challenging to study.
Fantastic. That's great, Matthew. I don't see any more questions. I'm really thank you for this presentation. I want to thank you about this overview. It's a bit scary to see the numbers that are probably coming in the next from the past year from the national labs. But this increase and this refresher has been very helpful, and touch on public health and prophylaxis is key. Hopefully there'll be a vaccine, and we'll see less of those infections in the coming future.
Absolutely.
Your presentation today and your contributions, and Thank you, everyone, for attending, and wish you all good rest of your day.
Thank you very much.
Thank you.